So I think just biologically, one of the advantages of taking a drug continuously, such as the way abemaciclib is administered, is mechanistically these drugs are halting the cell cycle. So they're putting the cell into a senescent state by halting the G1 to S transition in the cell cycle. And so the thought is that if you give the drug continuously, potentially you leave that cell in a prolonged senescent state that can then eventually lead to apoptosis. Preclinically, there is some concern that if you stop the drug and you give intermittent dosing, is it possible that those cells could sort of wake up again during that week off, and then you'd have to put them again to sleep with the subsequent cycle. And so there may be some advantage to continuous dosing. I think some people have argued, well, maybe that's why abemaciclib has, the 20% monotherapy response rate, whereas palbo and ribo are not associated with significant monotherapy activity. So it may be related to this whole idea of continuous dosing. I think clinically, before, we used to give these drugs when they were just even in clinical trials. And so at that time, we weren't so smart and drugs weren't packaged, appropriately. And so we would just give patients a supply of their palbociclib or ribociclib that wasn't just a 21-day supply. And I will say, I think Lindsay and I could both say that was a little challenging. We had patients who would forget, because particularly when you're taking, let's say you're taking an aromatase inhibitor with it, which is dosed daily continuously, but then you're taking another drug that's dosed only 21 days on, 7 days off. Well, it comes a little confusing, then you think you're just going to keep taking your CDK4/6 inhibitor along with your endocrine therapy, and then you'll obviously take too much, which could run into toxicity problems, particularly with neutropenia. But again, the drugs are now packaged appropriately, so patients only get their 21 days and then they have to go refill. And so we haven't run into that challenge. I think the challenge that I run into more is this whole idea if you need to dose modify and then restart the cycle. I think that's something we've run into challenges with in the clinic.
Right. For patients that say come in on day 15 for their lab check and they're low, then the question is, will they come back a week later? Will they get their labs checked somewhere else? When will they restart? What dose will they restart at? So I always try to tell people to be patient, or try to be patient for the first few months while we work it out. But after the first few cycles, we usually know what dose they're going to need and where they're going to be getting their labs. And so I tell people just, stick it out for the first few months and we'll get you on a plan, a good plan. So I think, I would say from a side effect standpoint, it's a little more straightforward with palbociclib, and most patients tolerate that drug pretty well right off the bat, except the patients that experience neutropenia and need dose delays and interruptions. Particularly with abemaciclib, which can cause more diarrhea and GI symptoms. Those are the patients I really say, we're going to work this out. You just try to, work with us and be patient, and we'll get you on the right dose and schedule. But that one can have a few more challenges. But most of the patients are expecting that because we prep them for it and we have a good plan to manage that. So it's not unexpected. It's just a matter of getting through it, which I think, again, most patients are thankful to be on an oral therapy as opposed to an IV chemotherapy. So there are very few people that are unwilling to put up with that, at least in the beginning.
I totally agree. I think it's a matter of patient education, so that when we see patients, particularly when we're starting a drug, that we've counseled them on what the expected toxicities are and then how to manage them. So for example, with abemaciclib, we know that about 80% of people are going to experience some level of GI side effects. And so we are very good about letting them know that, and we also counsel them on what to do if that occurs. We like our patients to call us if they experience any diarrhea, because it's important for us to know. Sometimes if people are having persistent, for example, grade 2 diarrhea that lasts over 24 hours, we do like to hold therapy and consider dose modification. And we also counsel our patients to make sure they've purchased loperamide prior to initiating therapy so that they have it on hand, and we've instructed them on how to use it. And I think that makes a world of difference. We also know that toxicity is very dose responsive. So if we, for example, reduce the dose of abemaciclib from the 150 BID dose down to 100, we definitely see improvements in symptoms, and patients tolerate it well. And now I think I feel comforted because I've also seen the data looking at outcomes based on patients who've experienced diarrhea versus not, and really there's no difference in progression-free survival whether or not they dose modified or not for diarrhea, and certainly I think that's very reassuring to see. And so I think our patients do very well simply because they know what to expect, they know how to manage the side effects, and then we can help guide them through it.